So let's go into the treatment of Parkinson's disease. We've made the diagnosis, we've distinguished from other disorders. What kind of treatments will we utilize? Well, it's important before we talk about drugs to talk about non-pharmacological treatment. This is important to institute in every patient. First would be education. Oftentimes, giving the diagnosis of Parkinson's disease results in a feeling of helplessness, loss of control, and providing resources, whether it be online or local patient support groups, which will hopefully be able to be back into function as we get further through this pandemic, but providing those educational resources is vital. Because Parkinson's is a long-term progressive disorder in which the patient will experience the symptoms lifelong, it's important to emphasize health maintenance because any other problematic medical condition, including disorders that are associated with pain, arthritis, back pain, any other chronic medical condition will exacerbate the symptoms of Parkinson's disease because it's a stressor on the body, complicates treatment, and so patients should be educated on staying up on their health maintenance, dieting, exercise, and addressing any preventable other health issue. Exercise is really the only intervention that has been associated with positive long-term and short-term outcomes. And while one specific type of exercise hasn't been demonstrated to be better than another, the duration of exercise is important, and the floor should be about 150 minutes per week. That's 20 minutes a day, 30 minutes 5 times a week. And this always has to be the foundation upon pharmacological treatments are added or any other type of treatment that must be instituted not only for short-term goals, but long-term maintenance of function. And then appropriate referrals outside of the immediate physician, including physical, occupational speech therapy. And because this is a loss of one's view of their selves, whether it be insofar as their ability to do their occupation or their position and station in the family, grief counseling is often necessary to deal with that loss, just like any loss in life. This is most particularly problematic for male patients, as female patients may have other support systems, friends available. It's really important to evaluate whether grief counseling might be appropriate as a non-pharmacological treatment. Okay, so let's talk about specific treatments now. So as I alluded to in the first slide, treatment, pharmacological treatment, other than perhaps exercise, remains symptomatic. So what that means is we're treating a disability resulting from a symptom. Again, no treatment has proven to be disease modifying or curative. And it's important to take into account various aspects when making decisions on pharmacological treatment. These include the time of onset and duration of the disease, obviously the age of the patient, the potential benefits of any pharmacological treatment, and of course, any short and long-term side effects. The goal of treatment is to support self-sustainment in activities, not the elimination of the presence, the visualization of a symptom. It is done to reduce or prevent disability and need for support, preserve independence and social competence, whether that be societal or familial, try to maintain the ability to work because oftentimes presentation of the disease is still within the prime working years for a patient, and maintain and regain any health-related quality of life issues that have been worsened by the disease. Okay, so let's talk specifics. So we've made the diagnosis, we've instituted all of the appropriate non-pharmacological therapies. Now the question is, do the motor symptoms, and we're going to focus on motor symptoms today, but do the motor symptoms provide cause a disability that impairs the patient's ability to do what they need or want to do? If the answer is no, then pharmacological treatment wouldn't be necessary. If the answer is yes, there is a functional impairment, then consideration for medicine is appropriate. And most of the time when this occurs, levodopa along with carbidopa will be instituted. Now, there's been this pendulum effect of how we approach levodopa treatment, whether we want to delay it or use it early, has gone back and forth over the years. And at present, the appropriate response is if there is functional disability that warrants treatment, then it is appropriate to initiate treatment with levodopa. There has been no proven studies, whether preclinical or clinical, to demonstrate a negative or toxic effect of levodopa. Additionally, you cannot save the benefit for later. So there is no value of saving it for later in life when the functional disability warrants its use, because the disease is synstatic and there's progressive loss of those dopaminergic cells. So at the present time, the pendulum is in the middle. When it's necessary to treat functional disability, it's appropriate to utilize it. Now, this is a complicated slide, but we're going to go through it because it's important to understand the pharmacological treatment. So we're going to start on the left-hand side. Again, levodopa is the agent that we're going to focus on. It is in the periphery, so we've swallowed the tablet. It's been absorbed through the small intestine. It's now in the bloodstream, and we want the levodopa to stay as levodopa. Because levodopa crosses the blood-brain barrier, we want to allow a certain level to be present in order to get enough into the brain. What happens in the periphery are there various enzymes that convert it to different chemicals. Specifically, levodopa is converted by dopa deep carboxylase to dopamine. Dopamine cannot cross the blood-brain barrier. So we give carbidopa, which blocks dopamine decarboxylase, along with levodopa. And that then allows enough levodopa to be in the periphery to cross the blood-brain barrier and sufficiently improve symptoms. If carbidopa wasn't given, we'd have to give very large doses of levodopa in order to have enough that doesn't get converted to dopamine in the periphery to get into the brain. And that's what carbidopa is utilized for. Most patients need about 75 to 100 milligrams of carbidopa to completely block this peripheral decarboxylation. All right, so levodopa has crossed the blood-brain barrier. It's taken up into those remaining dopamine-producing cells. We can also give inhibitors of the monoamine oxidase B to prevent dopamine from being broken down in the brain so that more dopamine is around to stimulate those postsynaptic dopamine receptors on the far right of the slide. The two available are selegiline, rasagiline, and sulfonamide, not listed on the slide here. Those are three that can be utilized to block that conversion. We can also give COMT inhibitors, including tolcapone and entacapone and opicapone, to block another enzyme to allow for higher levels of dopamine to be present. We can give agents that act directly on dopamine receptors and don't have to be converted like L-Dopa does. And there are a number of them listed on the slide below. We'll go a little bit more into depth as well. All right, so as I mentioned, most patients will require levodopa. The majority of patients eventually due to the functional impairment that's present. Oftentimes we will add a dopamine agonist or an MAO-B inhibitor. Sometimes we'll start with a dopamine agonist or an MAO-B inhibitor if the symptoms are quite mild, not producing significant functional impairment, but eventually levodopa, whether alone or in combination with these agents, are utilized. As we talked about, there are 3 dopamine agonists that can be utilized, including pramipexole, ropinirole, ratidogene. The first 2 are tablets. The third is a patch. And then we can also utilize the MAO-B inhibitors, rasagiline, selegiline, and sulfonamide. Again, these may be utilized in combination or in the case of selegiline and rasagiline as monotherapy as well.